Good afternoon, everyone. My name is Randa Eltayeb. I'm one of the diabetes and endocrinology registrars in London. I'll be talking today about diabetes in COVID. Are you able to see my screen?
Yes, we can see it.
Good, excellent. So I'm just going to start my talk today about diabetes in COVID. So there is a bidirectional relationship between COVID-19 and diabetes. In one hand, diabetes is associated with an increased risk of severe COVID-19. On the other hand, the new onset of diabetes and severe metabolic complication of pre-existing diabetes, including DKA and hyperosmolar hyperglycemic status, for which exceptionally high doses of insulin were warranted, has been observed in patients during the COVID-19 pandemic. These manifestations of diabetes pose challenges in clinical management and suggest the complex pathophysiology of COVID-19 related to diabetes. Severe acute respiratory syndrome coronavirus 2, or what we call it SARS-CoV-2, is the virus that causes COVID-19. It binds to angiotensin converting enzymes AC2 receptors, which are expressed in key metabolic organs and tissues, including pancreatic beta cells, which is responsible about insulin production. Also, it binds to adipose tissue, the small intestine, and kidneys. SARS-CoV-2 might cause pleiotropic alteration of the glucose metabolism that could complicate the pathophysiology of pre-existing diabetes or lead to a new mechanism of disease. The greater incidence of fasting glycemia and acute onset of diabetes have been reported in patients who have SARS coronavirus 1 pneumonia than among those with non-SARS pneumonia. For example, people who presented with encephalitis or presented with GI symptoms. The current evidence suggests that diabetes and poor glycemic control are risk factors for severe COVID-19, and that COVID-19 might precipitate diabetes-related ketoacidosis. Also, what we saw, people with type 2 diabetes are more higher risk and severe complication from COVID-19 infection. These observations provide support for the hypothesis of a potential diabetogenic effect of COVID-19. And beyond the well-recognized stress response that associated with severe illnesses lead to hyperglycemia, COVID-19 per se can cause a severe hyperglycemia through the ACE receptor. However, whether the alteration of the glucose metabolism that occur within the sudden onset in severe COVID-19 persist or remit when the infection is resolved is still unclear, and there is ongoing researches which we will find in the nearest future the outcome. Hence, it's important to examine these complex interactions between diabetes and COVID-19 further, and the setting of there is a global registry now called CovidACIM is an important step, and I'll talk about it at the end of my presentation. However, for now, until further evidence is available, what is important for us is to improve the glycemic control in people with diabetes to reduce the risk of severe COVID-19, as well as working on strategies that prevent the development of type 2 diabetes. As we know, in the last few years, the type 2 diabetes has been a pandemic and a global problem worldwide. How frequent is the phenomena of the new onset diabetes? Is it a classical type 1 or type 2, or is it a new type of diabetes that's associated with this pandemic? Also remains unclear. Does COVID-19 change the underlying pathophysiology and the natural history of the disease? Again, we need to do more researches to find out the outcome. What I'm going to talk about today for all of the colleagues around worldwide, I'm going to speak about diabetes emergency, diabetic ketoacidosis and hypoglycemia hyperosmolar status, HHS, which previously known as HONK, are the most common diabetic emergency that can cause high mortality and morbidity. Historically, both DKA and HHS were initially described as one entity, but subsequently we recognize they are both separate conditions. Their management are slightly different. Since the advent of insulin, the mortality has fallen for DKA and HHS both together, but still the risk of the disease remained high. So I'm going to start talking about diabetic ketoacidosis. For the purpose, I know our colleagues are using different parameters. So we use in UK the millimole as for the blood glucose. I know people in Sudan and America, they use the milligram per deciliter. For that reason, I put this table for the diagnostic criteria for DKA. When we talk about DKA, D is a stand for the glucose concentration, which is the diabetes, K for ketones, and A for the acidosis. If we talk about millimole, that means a glucose, by definition, glucose concentration more than 11 millimole per liter or more than 200 gram per deciliter in the presence of a previous history of diabetes. It can be mild or moderate or severe hyperglycemia. Talking about ketones, in UK, we have a wide availability of the blood glucose and blood ketones testing kit. Some area worldwide, they use a strips for a urinary ketones. Significant ketonemia means the blood ketones is more than 3 millimole, or a urine ketone on a standard dipsticks more than 2 pluses. Acidosis, we use a venous blood gas. In America, they prefer using arterial blood gas, but venous blood gas is very sufficient and you will be able to diagnose DKA. If the pH is less than 7.3, also if the bicarbonate is less than 15. It can be mild ketoacidosis if it's between 15 to 18 in terms of bicarb, moderate if between 10 to less than 15, and anything less than 10, that means this is a severe ketoacidosis. An iron gap of more than 10, this is mild, more than 12 is a moderate or severe. So to summarize, to diagnose DKA, you need at least 2 of these parameters to be present: hyperglycemia, ketonemia, or high urine ketone, and acidosis. In terms of management of diabetic ketoacidosis, number 1 is the fluid administration. The fluid of choice is the normal saline, which is 0.9% concentration of isotonic saline. The aim of the fluid administration is number 1, to restore the circulative volume, number 2, to clear the ketones, and number 3, correction of the electrolytes imbalance. Second thing in the management of diabetic ketoacidosis is the insulin administration. For the administration of the insulin, you use a fixed rate insulin infusion, which usually calculated by 0.1 units per kilogram. How would you make your insulin? So the preparation, usually you take 50 units of a soluble insulin, which is a short-acting insulin, whether that's Humulin S or Actarabit, and you add this to a 50 ml of normal saline. How would you give your fixed rate insulin is weight dependent, and I'll show you a table which can make things slightly easier. The aim of the insulin administration is number 1, to suppress the ketogenesis, number 2, to control the blood glucose, and to correction electrolytes imbalance. And what is your aim and what's your target? So when you start the treatment for the diabetic ketoacidosis, you have a certain biochemical parameters where you need to check the blood glucose hourly, and you need to monitor for falling of the capillary blood glucose by 3 millimole, which is equivalent to 54 milligram per deciliter. Increase of the venous bicarb by 3 millimole per liter per hour. Reduction of the ketones by 0.5 millimole per hour, and to maintain a potassium between 4 to 5.5 millimole per liter. When we talk about the ketones, if we are using serum ketones, which is the most accurate, is 0.5 millimole reduction per hour. For people who are using urinary ketones, one of the challenges is the clearance of the ketones in the urine might be more slower, so they can have a positive ketones for slightly longer duration. The management should be focusing on the clearing of the ketones by suppressing ketogenesis and normalize the blood glucose. To do that, sometimes you can end up by having still raised ketones, so you have ketonemia and you still have acidosis in the presence of normalized blood glucose. So for example, if your blood glucose has normalized or is fallen below 14 millimole or 252, you need to use a 10% glucose. Because the reason is, number one, if you continue with a fixed rate insulin infusion, patient can end up by hypoglycemia secondary to the insulin infusion. Number two, you would not be able to suppress the ketosis. That's the reason. Some guidelines are different. They use 12 millimole rather than 14 millimole as a cutoff. So these are three different tables from the Joint British Diabetes Society. The first table is to do with the fluids administration during DKA. So the volume deficit usually very high, up to 7 to 14 liters in a normal 70 kilo adult. To replace the fluids, one of the things you need to think about, if your patient has a cardiac history, or if they are elderly with impaired left ventricular function. Pediatrics, they have a different fluid administration policy. The issue is you need to prevent rapid fluid resuscitation and development of cerebral edema. So what you need to do basically, you need to have 6 liters of fluid. 1 liter you will give it a stat in the first hour, 2nd liter in 2 hours, 3rd in 2 hours, then 4 hourly, 4 hourly, and 6 hourly. During the process of giving IV fluids, you need to make sure you will assess the fluid status volume of your patient. That's number one, and you can do that by monitoring their urine output. Catheter is very important. Some patients wouldn't like to be catheterized. If they refuse the catheter, you can do hourly urine output monitor. The other thing you need to monitor while you're replacing fluids is replacing potassium. Reason is you're giving intravenous insulin, which shift your potassium from the extracellular to the intracellular. So you need to make sure your potassium levels are within the limit, which is 3.5 to 5.5. To maintain that, you will need to give a 40 millimole of potassium. People who have severe hypokalemia, you will need a senior review because they might need to be shifted to a high dependency unit to give more concentrated potassium. And they will need a cardiac monitor to prevent arrhythmias. Back to the insulin, as we said, we start with a fixed rate insulin infusion, which is 0.1 unit per kg. Make things easier, this table tells you if the weight, say, for example, between 60 to 69, you give 60 units per hour, and then depends on the weight. If the weight is more than 150 kg, you will give them 15 units per hour, but then you will need to speak to the diabetes team for further advice in terms of the insulin therapy, especially if there is no improvement. When can we say there is a resolution of the DKA? This is defined by a serum ketones less than 0.6 and a pH of more than 7.30. So if you manage to resolve your DKA, then your options are, number one, you can put the patient, if they are eating and drinking, back to the normal insulin regimen, especially if they are taking a long-acting insulin. One of the most important things in people with type 1 diabetes, if they presented with DKA, you need to make sure to give them the long-acting insulin, okay? Number two, the other option will be, if the patient is still unwell, vomiting, unable to tolerate oral intake, you use what we call it variable rate insulin infusion, or previously used to know as a sliding scale. I've put this table here just to let you know what we can use in terms of documentation of the insulin infusion. So this is the pathway for the fixed rate insulin. So basically it tells you about how much insulin, summarize what we said earlier, what is the criteria, including the ketones and the bicarb and the pH. And then for the insulin safety purposes, insulin should be countersigned by two nurses. Again, this tells you about the entry criteria, which we discussed, and this is the exit criteria. Exit criteria means your patient DKA has resolved. This table shows you the variable rate insulin infusion. So from the name called variable rate, that means you use a different insulin units per hour, depends on the blood glucose. So you can see, it tells you if the blood glucose, say for example, between less than 4, then you would use half unit per hour, between 4 and 7 is 1 unit, and up to more than 14. In terms of the variable rate insulin infusion, different hospitals, they have different protocols. Some of them, they have scales, depends on the insulin sensitivity and the measurement of the blood glucose. So it can be scale A, B, and C. But generally speaking, this is one of the standard variable rate insulin infusion chart. Any questions so far regarding to the diabetic ketoacidosis?
No, I think you should carry on, yeah.
Okay, so next thing I'm going to speak about now is the hyperosmolar hyperglycemia status. So it occurs mostly in adult and elderly patients. It has a higher mortality than DKA, with the death occurring between 5 to 16%. The unique distinguishing factor between hyperosmolar in comparison to DKA is the absence of ketones or a low ketone production despite an insulinic status. Patient with hyperosmolar, they present with a severe dehydration, which is due to the chronic nature of the hyperglycemia. You see that most commonly in elderly people who's not been eating and drinking for days. Both US and UK guidelines, they use a cutoff of osmolality of more than 320 millismolar per kg for the diagnosis of hyperosmolar status. So again, this is a table about the diagnostic criteria. So when we talk about hyperosmolar hyperglycemia, number 1 hyperglycemia, that means a serum glucose more than 30 millimole or 540 milligram per deciliter. And this is in UK. In US, they use slightly higher scale, which is around 600 milligram per deciliter. Hyperosmolality, that means osmolality more than 320. And lack of acidosis, so the pH will be above 7.3, and the bicarb will be more than 15, and in America they use a cutoff more than 20. Mental status changes can happen in both of the scales and the low ketones. In terms of the osmolality, calculation of the osmolality is 2 multiplied by the sodium millimole plus the glucose plus the urea. Or if you use the milliequivalent, is 2 multiplied by the sodium in milliequivalent per liter plus the glucose in milligram per deciliter divided by 18 plus the urea divided by 2.8. And this is just for the purposes of changing the units. Management of hyperosmolar hyperglycemic status, the goal is first of all to treat the underlying cause and gradually and safely to normalize the osmolality and to replace the fluids and the electrolyte loss. In terms of electrolytes, in the hyperosmolar status, you do see hypernatremia, and usually the sodium levels is above 150 millimole. For the sodium to be back to normal, it takes days, and you need safely to make sure you wouldn't drop the sodium rapidly. That means between 8 to 10 millimole per 24 hours. That's your target drop in the sodium. You need to normalize the blood glucose, which is usually in the hyperosmolar status, can happen with the fluids plus or minus insulin. And because of the severity of the dehydration in the hyperosmolar status is a very high coagulable status, and there is a potential for arterial or venous thrombosis. There is a potential of other complications like cerebral edema, central pontine myelinosis, which is, again, this is related to the hypernatremia. Foot ulceration can be seen. How would we treat the hyperosmolar? Again, the fluids of choice is the 0.9%, the normal saline, which basically your aim is to have a positive balance of 3 to 6 liters by 12 hours because they are massively depleted intravascularly. There is sometimes where you need to use a half of the normal saline or 0.45%. And this is basically if the osmolarity hasn't changed despite adequate positive fluid balance. When you start the treatment for the hyperosmolar, usually you can see initial rise in sodium, which is expected and self-limiting. And this is per se is not an indication for hypotonic fluids. The fall of the blood glucose, your target is 5 millimole per hour. You can use a low dose of insulin, which is 0.05 units per kg per hour. Usually, you can use that if you have, number one, fluidly resuscitated adequately and still persistent hypoglycemia. Number two, if there is a significant ketonemia. Any question about the hyperosmolar status? Right, next thing, we're going to talk about what we call euglycemic decay. Previously, they thought is a myth. Euglycemic decay is a clinical triad comprising of increased anion gap, metabolic acidosis, ketonemia or ketonuria with a normal blood glucose less than 11.1. And this is the reason why it's called euglycemic. That means because your serum or capillary blood glucose are normal, less than 11.1 or less than 200 milligram per deciliter. It's very rare, is a diagnosis of exclusion. Consider ketosis in patient with DKA, even if the serum glucose levels are normal. You should have a high clinical suspicion to diagnose euglycemic DKA. When do we think about euglycemic DKA? I'm going to talk about that in a minute, but you need to check if you have any very unwell patient, they coming for a different reason like sepsis, myocardial infarction, and they have a history of diabetes and they're very ill. The good practice is to check their pH and the urine or blood ketones because they can have euglycemic decay at that point. The underline of the mechanism of the euglycemic decay is either due to decreased hepatic production of the glucose during fasting state or severe illness or malnourished people, or because there is an enhanced urinary excretion of glucose. And we see this quite commonly with the people who are on SGLT2 inhibitors. Is difficult as a primary diagnosis. Having said that, during the COVID era, we saw a lot of patients who were admitted to hospital with euglycemic decay. SGLT2 inhibitors, one of the good drugs, is being used now for a few years and basically is being used in type 2 diabetic who has been either on metformin or insulin and they're not achieving their target. Currently, there is suggestive evidence of using SGLT2 in people with heart failure as well. People who are on SGLT2 inhibitors like empagliflozin, if they have vomiting, dehydration, being unwell for any reason, or they are coming for surgery, viral or bacterial illnesses, or even excessive ethanol use that can precipitate the euglycemic DKA. And for the Muslims population, we do tell them in Ramadan, if they are taking SGLT2 inhibitors, and they're gonna fast, to stop the SGLT2 inhibitors. But that needs to be done with a good monitor of their glycemia and under supervision of the diabetes team. Just a quick word about SGLT2 inhibitors. So basically, they are sodium glucose co-transport inhibitors. They enhance the glucose urea. So they lower the serum glucose by increasing the excretion of the glucose in the urine and reducing the sodium reabsorption. And this is why they can cause a volume depletion and low blood pressure and weight loss. If someone has intercurrent illnesses or they under any stresses like surgery, infection, fasting, or poor oral intake, what happens is the counter-regulatory hormones like the catecholamines and the corticosteroids, they start to increase the lipolysis. And because of the insulipemia, they will be increase of the fatty acid delivery to the liver and increase of ketosis. And this is precipitate the ketosis and the acidosis. And then because of the high levels of the glucose excretion in the urine, they will end up by having a normal serum glucose. And that's the cause of the euglycemia. And this is will explain why it's called euglycemic ketoacidosis. Briefly, I'm going to talk about hypoglycemia because, again, this is one of the diabetes emergencies, which is the condition occur if the blood glucose levels are too low, and basically is any blood sugars below 4 millimole or 72 milligram per deciliter should be treated. Hypoglycemia symptoms: autonomic, sweating, palpitation, shaking, and hunger. Neuroglycopenic like confusion, drowsiness, odd behavior, speech difficulties and incoordination, general malaise, headache, and nausea. There is multiple risk factors for hypoglycemia. Talking about COVID-19, so infection and illnesses is one of the major factors for hypoglycemia because of reduced oral intake. And again, it could be because of the medication. To classify the hypoglycemia, it would be mild, moderate, or severe. This classification, it depends on the patient orientation and conscious levels and the ability to swallow. If they are able to swallow, the easiest and the quickest way to treat is to give them a quick acting carbs like a glucose or like a fruit juice or glucose or like biscuits. If they have a moderate and they are able to swallow safely, if their conscious levels allows, then you go for oral. If not, you go for IV. And if they are unconscious, you go for IV. We do use IM glucagon, which is 1 milligram dose. But for the glucagon to work, it takes up to 15 minutes. One of the important things when we talk about hypoglycemia, if you have someone had hypoglycemia, number one, we will need to review their medication. Don't stop long-acting insulin. That's the message. Carry on the long-acting insulin, but you need a close monitor for the blood glucose. When you treat, you need to check and recheck in 15 minutes. If the blood glucose is 4 millimole or above, again, offer the patient to have long-acting carbohydrates like biscuits or bread. If it's still low, you will need to retreat again. If they are on oral hypoglycemic, and we think because of the current illnesses like sulfonylureas, you can stop the sulfonylureas and hold it for a day or two and then re-evaluate. Patient who has cardiac disease or renal disease, especially who has declined eGFR, they need to be reassessed. And if you need to treat them with IV dextrose, you need to be cautious and assess their volume and fluid status regularly. Take-home messages: DKA can occur in type 2 diabetics. euglycemic decay can occur in both type 1 and type 2. Mixed picture of HHS and decay can happen. Decay and HHS also can be a new presentation of diabetes, especially during COVID-19. The need for check either blood or urinary ketones for any patients who are admitted to hospital with a high blood glucose more than 11 millimole or more than 200 milligram per deciliter. Check for the osmolality if you think they are hyperglycemic, because could be a hyperosmolar status. During management, you need to think about anticoagulation with a prophylaxis low molecular weight heparin, because infection, decay, and reduced mobility during hospital admission, all of them are factors for predisposing to thrombosis. Electrolytes and potassium monitor and replacement as per guidelines. Feet examination is important to look for ischemia and ulcers. Watch for hypoglycemia. And the main important thing is to look for the precipitant and to treat the precipitant. So if it's infection, myocardial infarction, stress, pancreatitis, you need to look for it and to treat accordingly. Just a quick word about the CovidACIM. So because there is a high admission rate for the diabetic with diabetic emergency during the COVID-19 pandemic, there is an international group of leading diabetes researcher participating in COVID-Diab project, which is established now a global registry for the patient with COVID-19 related diabetes, and this is the website. The global registry basically is established the extent and the phenotype of the new onset of diabetes, which is defined by hyperglycemia, confirmed COVID-19, negative history of diabetes pre-admission, and a history of normal HbA1c. Given the very short history of the human infection with the SARS-CoV-2, an understanding of how COVID-19 related to diabetes develops, and the natural history of this disease, and appropriate management will be helpful in the future. Before I finish, last week was the Insulin Safety Awareness Week, and thank you very much for listening, and these are my references.
Thank you so much, Dr. Randa Eltayeb. That was really great, and an overview of diabetes management, and updating us on some of the concepts, and euglycemic DKA. This is I've not seen that, so I think that's really useful. Does anybody have any comments from the audience or from the panel? I think is Dr. Badri.
Okay, thank you very much. Very, very, very comprehensive and very fascinating presentation. I just question about the anticoagulation. I mean, like the heparin. Is there any preference for any type of heparin, whether low molecular weight heparin or in the management of patients with a DKA or hyperosmolar ketosis?
So in terms of the anticoagulation, it depends on the local policy and what the hospital usually use. In UK here, we use the low molecular weight heparin. One of the changes we noted during the COVID-19 pandemic, people who has hyperosmolar, we do use to treat them with a full treatment dose of anticoagulation, at least for 48 hours. But for that to happen, it needs to be guided by the consultant who's looking after the patient and the diabetes team, and to evaluate the risk. So it will be just a short period of a full anticoagulation for 48 hours. Having said that, most of the general practice now, they just use a prophylaxis, low molecular weight heparin, and that needs to be guided by the eGFR, because if the eGFR is less than 30, you need to readjust the dose.
Thank you very much, Dr. Randa. That was fantastic. So I think